Hi, everyone. My name is Felix, and I'm a second year med student at NOSM. Thanks for tuning in to listen to this presentation for the poster titled Severe Ototoxicity Following Prophylactic Cranial Irradiation for Small Cell Lung Cancer, a case report and review of mechanisms underlying radiation-induced ototoxicity. Before starting things off, I just wanted to take a minute to state that I have no conflicts of interest to declare. To give a bit of context and to sort of set the scene for the case, I want to start off with a bit of background information. Small cell lung cancer is a common type of lung cancer that is known for its metastatic potential, with many patients first presenting with late-stage disease and metastases. The brain is one of the most common sites for small cell lung cancer mets, and patients with brain mets have poor survival and treatment outcomes compared to patients without. For this reason, patients who have limited stage small cell lung cancer, meaning the cancer is limited to just the primary site in the lung, they're often concerned that small mets are present or could spread to the brain. Therefore, patients with limited small cell lung cancer who are treated with primary chemoradiation are recommended as standard of care to receive additional prophylactic cranial irradiation, or PCI for short, to help limit the risk of disease spread or recurrence in the brain. Ototoxicity is a well-known side effect of head and neck irradiation, most often seen in association to primary radiation treatments for head and neck cancers. However, because of the limited dose of radiation in PCI, ototoxicity has never been reported in association to this treatment specifically. To give a brief overview of the case itself, it follows a 42-year-old with limited small cell lung cancer who had no diagnostic evidence of brain metastases or other distant disease at diagnosis. They then received primary chemoradiation with etoposide and cisplatin, as well as targeted chest irradiation to the primary tumor site. PCI was then administered as the standard 25 gray in 10 fractions, and you can see in figure 1 on the right the radiation map, which details the dose distribution and estimated exposure of the various structures at the level of the inner ear. Near the end of the PCI course, the patient developed worsening vertigo, nausea, and vomiting, and were subsequently admitted to hospital. Over the following 6 months, their condition progressed to include profound bilateral sensorineural hearing loss and bilateral cataract formation. Since this time, they have had cataract and cochlear implant surgeries to try and rehabilitate their senses of vision and hearing. It's also interesting to note that this patient developed thoracic spine transverse myelopathy more than a year after their primary chest irradiation. Touching on a few key points about radiation ototoxicity, there's currently no well-established dose threshold for radiation ototoxicity. However, it's typically thought that doses exceeding 45 gray increase the likelihood of ototoxicity. In addition, it's known that potential sensitivities, genetic predispositions, or other pre-existing factors, such as prior exposure to platinum-based chemotherapy, may lower this threshold substantially. Lastly, multiple different cancer treatments can cause ototoxicity, but vestibular involvement is more typical of radiation ototoxicity, whereas platinum chemotherapy, which this patient had, is more frequently cochlear selective. Following this case progression, there are a few key discussion and learning points. Firstly, it's thought that the severe ototoxicity this patient experienced was a side effect from the PCI, which would make this the first ever reported ototoxic reaction to PCI. This is a rare and unique finding since the dose received by the inner ear during PCI was limited to around 24 gray and is not known to cause such a severe ototoxic reaction. Adding to this rare finding, the development of cataracts within 3 months of PCI is also atypical for a limited dose of around 700 to 800 centigrade received by the eyes. These findings, in addition to the recent transverse myelopathy, all suggest that this patient likely has a hypersensitivity to radiation. but the exact mechanisms and potential genetic predisposition remain unknown. Although very rare, these types of severe reactions to radiation can be quite debilitating and significantly impact quality of life. Taking this patient, for example, who had large losses in function to hearing, balance, sight, and now lower limb sensory motor function. This case actually points to a larger discussion currently being had in the literature around PCI for small cell lung cancer. A lot of the clinical trials and evidence that support PCI come from a time where high quality MR imaging wasn't readily accessible. And although PCI has been shown to significantly increase survival and lower the rate of brain mets in small cell lung cancer patients, there's always a conversation of de escalating cancer care. By limiting the amount of additional treatments, the goal is to improve these patients' quality of life after treatment by limiting the amount of long term side effects experienced, such as in this case. There's plenty of current research being done that compares the use of MRI as a brain met screening tool to traditional PCI for survival and outcomes in small cell lung cancer. There is conflicting evidence, but some too suggest that the use of PCI offers no additional benefit to these groups of patients over MRI screening. To wrap things up, I just wanted to touch on a few takeaways and conclusion points. Following on what was said previously, with improved and more accessible MRI, more research is needed to re-examine the use of PCI for small cell lung cancer. Overall, sparing patients from additional radiation treatments or cancer treatments in general is beneficial in preventing negative autologic reactions. Predisposing factors render certain patients more sensitive to radiation ototoxicity. However, identifying these patients prior to treatment remains a challenge, and unfortunately, they're often found afterwards, where the primary goal becomes supportive care rather than prevention. So thanks again for taking the time to tune in and listen to this presentation. I hope everyone was able to take away a few things from it. Thanks.